I'm Dr. Marla Shapiro, a past president of the North American Menopause Society, and I'm joined by a member of the Board of Trustees of NAMS, Dr. Lisa Larkin. Lisa is a women's health internist and the founder of a company called Ms. Medicine, which is a women's health company committed to advancing evidence-based gender-specific primary care. So many migraines. So many migraines out there. And as primary care providers, internist providers, where do we go with the management of these and how do we treat our patients?
Right, so it's not just primary care, it's all women's health clinicians, and I would say that this is in the purview of obstetrics and gynecology as well. So migraines are highly prevalent in women. 18% of women experience migraines. And like many other women's health conditions, they often go undiagnosed. This is an area of unmet medical need in women's health, and it's really important that we address this. So why? It causes huge disability and really quality of life, but really impacts work and all kinds of daytime functioning. The other thing is we know that women go undiagnosed and untreated and have inadequate treatment for many years before they actually even get to a physician and talk about their migraines. And the issue with that is migraines start off as being infrequent. There often is a hormonal component. We see them accelerate in the perimenopause, but they can become chronic and much more frequent. And so early introduction of abortive therapy, treatment to treat the actual migraine, and discussion and consideration of preventative therapies is really important early.
You worry about people who over-medicate with over-the-counters and then end up with rebound headaches.
Right. So, again, that goes back to this discussion of we really need to appropriately diagnose a patient so we can institute correct treatment for that patient, again, to prevent the rebound headaches, but also to prevent the progression to chronic migraines.
Therapies, what's out there?
Right, so there's great medications that have been available for a long time called triptans, and we know that, again, they're very effective and underused. This is a great time in migraine development, research and development. This is one of the areas now where it's very exciting that basic bench understanding of the pathophysiology of migraines has really advanced, and that has led to a new treatment paradigms now. So in the past, we really thought that the triptans and these other medications we are using work by vasoconstriction. We now understand it's a much more complicated pathway that involves the trigeminal nerve and molecules called CGRP. And the new targeted therapies are now monoclonal therapies directed directly at CGRP, and there's a whole new class of preventative medications and now up and coming some abortive medications that are highly effective and I think is really going to change how we manage migraines going forward.
So with some of these newer therapies that are they daily, are they injectable?
Right, so the abortive therapies, the triptans, which we use, are at the time of the headache. And again, earlier, women should be advised to take them very early. The earlier you take them in the headache, the more effective that they are.
But only so much a month. You can't overuse them.
Right, so we're cautious, and that's when, again, if women are having more frequent headaches, and the number varies a little bit, but let's say 6 to 10 migraines a month, that's when really women should have consideration of preventative therapies. Mm-hmm. The problem is we've had lots of preventative therapies that we've used in the past, so some of the antidepressants, some of the anti-seizure medications, they all have really significant side effects, and we know that compliance and women using these medications drops off very quickly. The good news is now with these new preventative therapies, these new CGRP medications, they're injectable, which may be a barrier, monthly injectable, but their very targeted side effect profile is very low and they're very effective. I can tell you I've been using them now in practice for about a year, and the success has been tremendous with patients, decreasing frequency and severity very quickly with these drugs with very low side effect profile. I think it's a really exciting time in migraine management.
So I think the bottom line is that we've got to be taking a history to see if women are having these.
Right.
And make sure
for
that
sure. And I also would encourage that not just internists, but OBGYNs should really become comfortable with these medications because they're really, as much as it seems that it may be a barrier to talk about treating migraines with these injectable medications, these are easy to use and you can demonstrate them to patients. It's like an EpiPen and they're very effective. And my belief is that really we're going to shift the whole paradigm soon into using CGRP medications for both abortive and for preventative going forward. So I encourage all the clinicians to get used to these drugs.
And that's why you're here. Thank you.
Thank you.